Good afternoon. My name is Nick James. I'm here with Jeff Karnes and Prof Witjes in sunny Barcelona for the European Multidisciplinary Urology Conference. So we're here to talk about the highlights of the meeting here in Barcelona, and I'd like to start with something that actually was quite a small thing, but I think quite an important practice point, which is if you have a patient who's got hydronephrosis and a bulky bladder tumour and you want to give them platinum, do you stent or do you put an F tube in? And our practice has been to stent because we worry about chemo with a percutaneous hole as being a route in for infection. But George Salmon showed data from his own department relating to a risk of upper tract recurrence if you put a stent in as opposed to leaving a percutaneous tube as the route in, which was data I hadn't seen before. It was very interesting and I think quite an important practice point. It's not an uncommon problem. And so I'm just very interested in your take on that.
Yeah. I agree with that. It mirrors my practice, but for a different reason. So it was news to me to see the data from Bern with the upper tract recurrence. But one reason that I prefer a percutaneous tube over a stent, if they're going to go to surgery, is just because the stent usually incites a lot of inflammation of the ureter, can complicate the anastomosis of bowel to the ureter. And even if patients are going trimodal therapy, usually prefer the percutaneous nephrostomy tube to the stent, just because a little bit of local irritation from the double J and the radiation.
Yeah, I think I agree on that, especially during surgery. Double J gives some inflammation. It's not the best thing to have. And if there's hydronephrosis, that means that there's, of course, tumor at the ureterocostium, which sometimes means it's difficult to get in a tube either from below or from above. Yeah. So we usually give a perc.
Yeah, and as we were saying earlier, the thing you can do, of course, if you get a good response, you can take the thing out. Yeah. But I entirely agree about doing radiotherapy with tubes inside. You get more bladder, you get more irritation. Yeah. So my second highlight was Silke Gillison's presentation on the APCC consensus meeting, and there were some quite striking bits of data she presented, and I was very struck, and as surgeons I'd be interested in your take on this, that at both the meeting and in the audience today, she got us to vote on how many lymph nodes you should take out with a high-risk N0, M0 prostate cancer. So quite a technical thing, but there was a remarkable degree of consensus on it. Everybody said you should take out 10 to 20 nodes or something, an area with no data, really. And I'd just be interested in what you do and whether you think you could even get data, whether the data might be relevant.
Well, I mean, I think it mirrors a little bit of the bladder cancer practice, that the more lymph nodes you take, the better you stage the patient. And I think that the take home is, if they have a risk of lymph node involvement, then you should do an extended pelvic node dissection and not just a sampling. Yeah. I think most people would agree on that. I think the number of nodes is dependent on the institution. You could do the same dissection, at least someplace in the U.S., and go to a different place in the U.S. and maybe get different nodes related to the handling and everything. But I think the extent is the most valuable aspect of doing the pelvic node dissection. There was some data in patients who have a pathologic node finding, but clinical node negative, that the more lymph nodes that you sample, the better the outcome in pathologic node positive disease. Yeah.
But that may be a surrogate for the competency of the surgeon, of course, rather than the therapeutic efficacy of the actual procedure.
And also mirroring what we see in bladder cancer.
Yeah, although I do agree, it's not basically the number, but it's more the extent. There's been a very nice study from the Netherlands. That was in bladder cancer, by the way. Yeah. Looking at a group of surgeons operating in 2 hospitals, everything the same surgeons, same patients, everything the same, but different pathologists. And the number of nodes in one center was 16, and the average number in the other center was 27. And the outcome was exactly the same. So it's basically more the extent. I was, by the way, looking at Silke's presentation, surprised that there were 150 questions where there's no consensus. There's more no consensus than there is consensus.
Absolutely. Yeah. But for the node thing, though, one of the things that's because this is an endless discussion we have in our MDT, and one surgeon, there's always like 30 nodes, and another one there'll be 5, from the same department. And but even the guy who's the most senior guy in the department, who does the most nodes, he says, well, this isn't a therapeutic procedure. This is just very detailed staging. And do you think it is therapeutic, or do you think it is just fancy staging? And if you think it's staging, do you think things like PSMA PET will make that sort of pathological staging redundant?
Well, I think it's predominantly staging, although we all have, as urologists, and you know them too, Nick, patients that have had 1 or 2 nodes that never get a recurrence again. And what I now see when we do MRI for nodes or PSMA scans for nodes, you see nodes on spots where I basically never went before, pararectally or on other spots. So again, our usual extended node dissection probably doesn't cover it all. But if we would cover it all, maybe there is some therapeutic value in that.
Completely agree. I mean, I think the whole realm of molecular imaging, especially in the post, definitive therapy recurrent state, has shown us all these sort of atypical nodal spread that we would never have been in our template when we did the original surgery. In addition, I do think it's predominantly staging. I do think there is a therapeutic aspect to the pelvic node dissection, and some of that comes from the salvage lymph node removals that we see, or even the salvage radiation therapy we see to limited oligometastatic nodal disease, where there have been some decent long-term cures.
Absolutely.
Jeff, do you change your node dissection based on imaging? Primary or salvage, of course?
So we do PET choline imaging. However, it's not indicated in the primary staging.
Okay.
So it's rare for us to have a primary staging PET scan, just because it's not reimbursed in the United States.
So it's creeping into us. So I think one of the areas, coming back to the consensus conference, where actually mostly there was no consensus, but we've invented a whole new disease, haven't we? Which is sort of oligometastatic primary, oligometastatic recurrence, oligoprogression in patients with multiple.
There's no D0 disease anymore. It seems like, right?
No. Well, in our practice, M0 CRPC has almost entirely disappeared because we just watch people's PSAs go up and we do PET scans. And then, as you say, you find nodes in places that were never in the standard, anatomical distribution of nodes that we may or may not have irradiated already. And so I think there's going to be a lot of very interesting stuff coming out around.
We'll get a totally new patient cohort with outcomes we don't know yet.
Well, certainly in our practice, we're just imaging more and more and more. We don't, because unlike the States, we've got really good access to imaging, so we're imaging more and more and treating less and less. And increasingly, you do a PET scan, you find there's one node, you sort of do a sort of involved field around it with a 3-month shot of hormone therapy, then stop everything again. And then a year later, they pop up something else. But they end up on
That's what you mean with more imaging and treating less, because I would guess, based on imaging, you would treat more?
Yeah, because in the past, you'd have just what their PSA would have got to 20 or whatever it got to. Our threshold for PSA, for M0, rising PSA, starting hormone therapy was going up and up and up anyway. But it was arbitrary, wasn't it? And the striking thing is patients' PSAs will go really high and you can't find anything, even on a PET scan. And I think they're much better off not on treatment, I think.
Yeah, I think the whole concept of metastasis-directed therapy is one of the explanations I give patients is let's try to make this a chronic disease. And there are some of these prostate cancers, typically the Gleason 7s, that I think you can sort of pick away at, if you will. Combination of surgery, radiation, ablations.
Yeah, it generates lots of heat.
Well, you can see. There was a statistician's view that was presented yesterday on PSA screening, for example. If you see how few patients have problems in 10 years, that was 1%. So the guy said, I'm not going to have a PSA test.
Well, that was one of the very striking things about the PROTECT trial, wasn't it? I mean, I know it was published previously, but not this year, but it's very striking that nobody was dying from prostate cancer. And one of the things, just to segue into the STAMPEDE data, so I'm talking about that tomorrow. I know it's CRPC day today, as it were, but we showed some data at ESMO, because we showed the abiraterone data at ASCO, and obviously it exactly mirrors the latitude data as well. And so you've got this massive effect on survival, even bigger effect on failure-free survival, obviously depending exactly how you measure it. But the very striking thing was all the effects were bigger in the M0 subpopulation than they were in the M1 population. STAMPEDE has the whole lot. And so we showed data at ESMO on just the M0 outcomes, which the survival's immature. But of the N0, M0, patients who'd had ADT, radiotherapy, plus or minus abiraterone, virtually none of them had died. And these are patients T3, 4, PSA 40 or above, Gleason 8 to 10. It's like really high-risk patients. And even the node positives, over 95% of them are alive at 4 years if they had all three. It's quite striking. Yeah,
but you're running into, I guess, logistical problems, financial problems, I'm afraid. And what about quality of life?
Well, the interesting thing about the financial problem is that the effect on relapse is massive. So you've got a 70% reduction in relapse. And in the M0, we capped the treatment at 2 years. So at 4 years, you've got something like 50% of relapse with ADT radiotherapy versus it was under 10% had relapsed.
So that's where you save
if
money.
you added Abi. So you've got a very large period not having any treatment if you shove relapse that far out. And we've just done, and this is data that's not even in the public domain, but we've just done the health economic analysis on the docetaxel STAMPEDE stuff. We're going to show it at GU ASCO. And it turns out the effect on delaying relapse is the same. It's 40% delay in relapse. Not quite as big, but it's the same sort of phenomenon that you stop your treatment and then you don't have any treatment for a very long period of time if you've shoved the relapse out 40%. That completely wipes out the costs of the docetaxel and gives you a quality of life gain, even though you've given them chemo at the beginning. So the DOSI data, the health economics, is cost saving in is more cost effective in M0 than M1. So it's pretty modest cost in M1 as well. So yeah, compared to abiraterone, obviously, it's very different. The thing about abiraterone, though, is if you look at the average length of treatment on abiraterone in the metastatic patients in STAMPEDE and in Latitude, it's remarkably similar, is about 3 years. The average length of treatment with Abi or Enza in CRPC is about 18 months. So you're not paying for 3 years of treatment, you're paying for 18 months of treatment. But if you look at what you get for that, if you give 18 months of treatment in CRPC, you get a 6-month survival gain. You give 3 years, so an extra 18 months, you get a 3-year survival gain. So the extra 18 months gives you an extra 2.5 years of survival. So probably it's more cost effective in upfront than in relapse. But it is actually also more costly, of course.
Yeah, but I guess in the end, if people relapse again, they're probably going to use the same drugs again.
Yeah, well, what we showed data on that at ESMO on patterns of care post, because in the middle, the Abi and the DOSI arms overlapped in STAMPEDE. So we've got 600 men effectively randomised to abiraterone or docetaxel as upfront therapy. And so we were able to look at the impact on survival. So Matt Sides did a really nice presentation on this data at ESMO. And so I'll talk about it a bit tomorrow. But basically, the effect on overall survival was the same. You'd have thought from the hazard ratios that it was going to be bigger with Abi, but it turns out that for the patients actually randomised head-to-head, it was the same. Time to progression was much longer on Abi, but of course you've given Abi until they're Abi resistant, whereas you've just given 6 shots of DOSI and then you come back. So you've actually given a lot less treatment to the DOSI patients. But if you looked at endpoints like skeletal events, the time to skeletal event was the same on Abi or DOSI, because it's quite a late thing. And so basically, what happens is if you give upfront Abi, you're going to have a long period relapse-free, but actually once you relapse, things happen fast. Whereas it's the other way around with DOSI. You've got a shorter period of time to relapse, but you've got a lot more options, including Abi, still to come. So things happen much more slowly. So what you get first, not very surprisingly, affects what happens later.
So in 2018, what do you think the standard of care is going to be for a newly diagnosed castrate-sensitive prostate cancer?
Well, in the UK, NHS England just sent a letter around saying, guys, you're not allowed to use abiraterone, whereas docetaxel is already NICE approved and reimbursed and all the rest of it. So that's not going to, whatever the science says, the funders in the UK are saying, give the cheap stuff, guys. Okay. So obviously that begs the question, if you're not fit for chemo but are fit for Abi, which is obviously quite a lot of patients, obviously you'd like to give these patients Abi. But I don't know how does it pan out in the States where you may or may not have a copay to give with it? Because I've heard that clinicians are offering people docetaxel for that reason, for the cost.
Absolutely. I mean, the most insurance companies are not picking up the abiraterone for first line in castrate sensitive. They're not picking it up currently.
It's the same for the Netherlands. It's not reimbursed in the first line. So it is in the second line, but I guess that will change one of the coming years.
The data's pretty fresh.
Do you think there's any role for profiling, like the AV7 or whatever?
The trouble is if you look at the profile, basically, Abi, if you look at it in CRPC, you've got an 85% response rate. So you can at best only pick 15% out. It's probably a higher still response rate first line, because everything works better if you haven't had prior treatment. Talking to people like Gert Assad and Johan de Bono, who part of the STAMPEDE team, they were saying the rates of ARV7 in newly diagnosed patients are actually very low. So you wouldn't be able to take very many. But if you did do it, I guess you'd say those patients should get chemo. Yeah. But it wouldn't help you very much.
Small percentage.
Yeah.
We'll go back to the comparison of abiraterone versus docetaxel with the the PARP inhibitors, which I assume are more expensive than conventional platinum chemotherapy, which has been shown to be sensitive to those BRCA-type tumors.
Yeah, so one of the things that's happening a lot in the UK, and I assume it's happening everywhere, is it varies as to how easily we can get this sequencing done and how comprehensively. But I'm guessing that it's going to become more commercially available anyway. So, but you've got patients who've got a very clear family history, for example. They think, well, we'll just give them a shot of platinum-based chemo just to see what happens. And we've got a few patients where they've had amazing responses, having failed to respond to docetaxel, say. And you're right, it's a lot cheaper. I mean, it's like with the abiraterone thing, though. People would rather take pills than have chemo. I mean, understandably. So there's obviously none of these things are licensed in prostate yet. So there's a bit of there's a bit more game to be played here before we end up.
But that will change in the coming few years, I guess. Yeah. So what about immunotherapy? I heard yesterday about cold tumor, warm tumor, or hot tumors. Is there a role for any kind of pre-treatment prostate cancer before giving or looking at immunotherapy? Again, that's another thing we're looking at putting into STAMPEDE. So Tom Powell's he's obviously been key to the whole story. Has been looking at it for us, and at the moment we can't. There doesn't seem any very convincing phenotype that you can use to identify responsiveness. Just going back to the responsiveness thing. And I mean, but these drugs work so well almost everywhere else. You'd imagine there must be some sort of role. But again, I think there's a bit of work to be done to figure out exactly where. You don't see that coming within a few years? Well, I think it's probably going to come. There are trials recruiting. Like we've got a trial that's opening where, there are, not microsatellite instability, for example. If you've got a lot of that, it appears to. So, and all of these things get more common as you go down through multiple lines of treatment. And obviously, we're shoving patients through lots of lines of treatment now. So I think we're going to see these things appearing late in the pathway. Increasingly, and they're so well tolerated. I mean, they're really very easy drugs to give. I mean, you get these, a small number of patients will get really bad immune, colitis or lung or whatever, but mostly these drugs are very well tolerated. You can give them to sick people. And do you think that, for example, what was told yesterday, I think Silke told that if you would irradiate the tumor, that you will induce the ability to give chemotherapy, immunotherapy? Well, that is one of the things that is, it is very interesting, and it does appear that, slightly surprisingly, you think radiotherapy would be immunosuppressive, but it appears that it's immunostimulatory, particularly if you give a big dose, small number of big fractions, it appears to be immunostimulatory. If you look at how radiation kills cells at sort of the 2 gray per fraction type standard doses that are used, mostly you're looking at single-stranded DNA breaks, some double-strand breaks, and if you line the single-strand breaks up, you can't repair them. You don't actually kill the cancer cells, or kill any cells at standard doses. It's below it. If you go to much bigger doses per fraction, you start disrupting cell membranes and all sorts of things. So you're actually getting necrosis as opposed to apoptosis, and that's much more immunogenic. So I think there's some sort of explanation, I think, about how radiotherapy might be immunogenic around inducing necrosis and therefore inflammation versus inducing apoptosis, where you don't get a lot of inflammation. Sure. So it does kind of make sense. It was presented yesterday by the combination of ABI and immunotherapy. Again, that apparently also gives some kind of response or reaction which improves the efficacy of immunotherapy. Yeah, no, I think there's a lot of, I mean, generally in oncology, the lesson is that things work better in combinations. If you just do one thing on its own, surgery, radiotherapy, whatever, you'll get whatever result you get. But to get better results, you have to start adding drugs or whatever in, don't you? And I mean, that's the lesson with bladder cancer, isn't it? I mean, the surgical results have been, consistent, but but no improvement. I mean, it's not plausible you can improve it really. I mean, you can do an operation better, but fundamentally, you either take the thing out and it's gone, or it's not gone. No, you have to combine treatments. That's obvious. So I think the immunotherapies in bladder are going to be transformational. I think. There are trials in every stage of bladder cancer, even in high risk, non-invasive. So it's expanding a lot. Yeah, well, I think so. I'm particularly interested in that because I think obviously that's an area where you have an immune treatment already approved, which, as far as I can see, it does work, but it's quite toxic, isn't it? I mean, not that many patients get all the way through a full induction maintenance. And so I think that is, there's got to be better ways of doing an immune system tweak than
than giving somebody BCG.
Yeah, and if you can choose for pills or an intravesical installation, I think the choice again will be not that difficult.
Yeah, so I think those trials are going to be very interesting.
It was really nice to see what's happening now in prostate cancer, whereas 10 years ago we didn't have anything. And I'm very curious to see what we're going to treat in a few years and what the sequence is going to be, because that's another question. But that landscape is going to change significantly in the coming few years.
It is, yeah. No, it's worth remembering, isn't it? This is, 10 years ago, docetaxel had just been approved a year or so previously, and that was the only drug, apart from ADT and stuff. Yeah, no, it's very interesting. Great. Well, I'll wrap up by thanking you both, and enjoy the rest of the conference.